The Coffee Hour. Welcome to Coffee with our morning host. We broadcast a host of programs like current topics, newspaper headlines, and music on Radio Sri Lanka. Tune in every weekday from 7 to 8 a.m.
Delving into the branch of medicine, dealing with the diagnosis and treatment of all categories and conditions. And this is as involving the nervous system, which comprises the brain, spinal cord, and the peripheral nerves. To share his valuable insight and to give us his expert comments on this very wide area, we have with us this morning in the studio our special guest, Dr. Gamini Pathirana, consultant neurologist, National Hospital of Sri Lanka. A very good morning to you, Doctor, and a very warm welcome to Coffee Hour.
Good morning, Saundi.
And well, as we are aware, Doctor, neurology is a vast area covering many ailments, from a simple headache to Alzheimer's. It's a huge scope. So, well, let's start at the very beginning. Can you tell us, please, what the unexplained symptoms is or signs that a person should have to realize that it's time for him or her to see a neurologist, and what he or she can expect during the first consultation with the neurologist?
Yes, first of all, let me thank your channel for inviting me today for this coffee hour.
You're most welcome.
And neurology, as you quite correctly said, it's a vast area. And if you think of symptoms that a patient might come to see a neurologist, again, it would be very vast. Common problems, if you look at, to name a few, as you correctly mentioned, headaches are very common. There are many types of headaches. And then, stroke, another common problem, which can be prevented, and we are doing a lot of education stuff on stroke prevention. And if you look at Parkinson's disease, another area that is fairly common and probably disabling as the disease progresses. And dementia, again, something to do with brain again, which is common in older age, that's reasonably common in old age. People, Sri Lanka is having an aging population now, so we are seeing more and more dementia patients. In addition to that, there are so many other neurological disorders. In fact, we divide neurological disorders into broadly two groups. First, being short-term neurological disorders, they usually recover on their own. If I am to mention one example, Bell's palsy, something that is very common, where you lose power of one side of the face. Your mouth goes to a side and you find difficult to close your eyes, and it settles on its own. It's a common thing. And there are long-term neurological disorders. That's the second group. I mentioned a few. And the long-term disorders also divided into two groups. They are progressive. Some of them are progressive. For example, Parkinson's disease and dementia, the two disorders that I just mentioned, they're actually disorders. And there are non-progressive long-term disorders where you have the disease, and then the disease causes some, we call it neurological deficit, or in the simple terms, causes disability. And then you're going to live with that disability for the rest of your life, but it's not going to progressive. So long-term neurological disorders, again, divided into two groups, non-progressive and progressive.
Right, so those are perhaps the early symptoms that people have, then they will know that they've got to go and see a consultant neurologist, am I right?
Yes, there's a common ones, and in addition, there are others like, you feel numbness in your hands and feet, which is actually part of peripheral nervous system. Common problems like carpal tunnel syndrome, which is a fairly common problem among people who work with using their hands frequently, and a lot of diabetics have this problem also, where your hands become benumb and then painful at nights and find difficult to work with using the hands and so on. And diabetics have a lot of neurological problems like peripheral neuropathy, where your feet become benumb and burning, and we can't sleep at night, it's painful. So nerves can get damaged by diabetes. There's a whole lot of peripheral nerves disorders as well.
Is a constant headache, doctor, a cause for concern? A constant headache, maybe not something to do with the eye. Somebody has got their eyes checked and got that attended to, but they still have a constant headache because that's something very common. So is that a cause for concern?
Headache is a common problem in community, but vast majority do not have a serious underlying cause. Doctor's task when a patient with headache arrives to the doctor is to, distinguish serious underlying causes from non-serious causes, which is a difficult task. And doctors have been trained to how to differentiate them. A vast majority do not have an underlying serious pathology. The common causes are actually serious, non-life-threatening, non-progressive things like migraine, tension headache. They are common. They just cause you headache, and you sometimes find it difficult to study and go for work, and it affects your work, day-to-day activities, but they are not life-threatening. They are not going to make you disabled. But on the other hand, there are serious causes of headache, like for example a brain tumor or infection of the meninges. We call it meningitis. And then a person may come to the doctor with sudden severe headache where he never had headaches before. And we have heard this kind of stories, young male or female patients coming to hospital with sudden excruciating thunderclap headache. And some of them die. We have heard some of them have died. A small percentage having serious underlying causes. So if you have a headache going on for a number of years, 5 years, 10 years, I have headache from my childhood, the chances of having a serious underlying problem is low. But if you're having a recent onset headache, maybe I have headache for last few weeks, maybe or 3 weeks, I had this headache this morning, doctor's going to look at you to rule out serious underlying problems.
Right, and doctor, while talking you mentioned stroke. Focusing on brain strokes, it is known to be globally the second leading cause of death and the third leading cause of disability. Can you tell us what a brain stroke is and the symptoms we should be watching out for?
Stroke is a problem. Apparently, if you go by the data, 1 in 4 individual is likely to get a stroke during their lifetime, right, according to the current data. So it's a fairly common one, and it's going to make you disabled for the rest of your life. So you are walking now, you are talking, and you are eating, everything is intact. In the next moment, you're going to get disabled, and you're going to live with that disability for the rest of your life. So something to be concerned. And out of the stroke patients, 90% of them seems to have had, going through the data, that they had 10 preventable risk factors causing them to have the stroke. Something to be aware. So stroke is a serious problem. A small percentage die during the stroke, acute stroke, and a large number become disabled for the rest of their life. You become dependent on someone else for the rest of your life, and you will not be able to work anymore, function normally. The music that you enjoyed, you played, you might have to stop after you get the stroke. So your life becomes miserable after getting a stroke. So stroke is caused by risk factors that you are having in your system at the moment. For example, if you are having high blood pressure without your knowledge, you must check your blood pressure if you are more than, say, 30 to 40 years of age, at least once a year. If your blood pressure is increased, the doctor will ask you to take tablets. You must get it checked yourself. And if you are a diagnosed patient with high blood pressure, you must continue to take your medications and make sure that your blood pressure is at the target level. Discuss with the doctor. Not only blood pressure, it's blood sugar. The second commonest reason why people get stroke, uncontrolled increase blood sugar levels. So if you are a diabetic, you must make sure that your blood sugars are controlled. Not that you are just taking the medications is not your goal. You must make sure that you reached your goal target level of blood sugar. These are two common causes. There are 10 of them. We discuss the others as well.
And doctor, one more thing, is obesity also a cause for a stroke?
Yes. So among the rest of the 10, you have, first, most important cause is high blood pressure. Second would be diabetes. Third, your increased cholesterol level. If these three are not controlled, your chance of having a stroke is very high. So if you want to find out whether you are now healthy, but am I going to get a stroke in the next maybe month or next couple of years, you should check your blood pressure, blood sugar, and also your cholesterol levels. That will tell you whether you are in the direction of getting a stroke. And other risk factors, including, as you mentioned, obesity, which also is a measurable thing. We can measure depending on your weight in kilograms and height, and you can calculate your body mass index. You know how to calculate this in the internet. So if you are obese, if you are you're not taking too much exercise, you are sedentary, and if you are smoking, if you are taking too much alcohol, and you are stressed up physically or mentally, all this add for you to to get a stroke.
So basically the lifestyle also has a lot of impact, isn't it?
Exactly.
And moving on to Parkinson's, which is also another ailment that is no respecter of persons, isn't it? It comes on. Are there any known causes, doctor, for this disorder to set in?
We understand Parkinson's disease, the root pathology to a certain extent. Unfortunately, we still do not have control over it. We cannot eliminate the root pathology. We don't have full control of, at least to prevent progression of the disease. We understand this is due to deficiency of a chemical, a neurotransmitter, we call it in neurology. The neurons talk to each other using a chemical in between neurons. So a deficiency of a neurotransmitter by the name dopamine.
Just to interrupt you there, doctor. So is that something that is secreted by the cells?
Yes, actually nerve cells are like wires.
Right.
So in between nerve cells there's a space through which the communication takes place through chemicals.
Right.
And there are many chemicals in the brain they use to transmit impulses across nerve endings.
Right.
One of them is dopamine. There are a few others. So deficiency of dopamine leads to certain circuits in the brain to become dysfunctional. Which patient is going to develop this depends on probably genetic factors and environmental factors. We do not fully understand that. But, few people in the society, as you grow older, gets this. No one can predict who is going to get it, but few people seems to get it.
And it is commonly understood that though unable to cure completely, it can be controlled. How is that process carried out?
The disease, the root pathology actually is not under control. What we do normally is to treat the symptoms. We have very effective symptom treatment available. They are so effective that patients feel that they are cured. In fact, we must give the credit to a guy by the name Carlson. In 1960s, he won the Nobel Prize for discovery of this particular medicine, dopamine, which is at the moment is a main drug world over being used to manage Parkinson's disease. The deficient chemical is replaced by giving it as an oral tablet.
And in Sri Lanka, are we equipped to handle this ailment on par with world countries such as in the medication available, the therapy needed, and the required expertise and knowledge of the issue?
Yes, we can manage the Parkinson disease in par with the rest of the world, except in the advanced palliative phase. There are certain very expensive treatment options which we do not have in Sri Lanka. But this is a life-limiting illness. When I say life-limiting, you're going to live with this disease for a number of years. It's not few months or few years. It's going to be 8 years or a little longer. So different people have different rates of progression. So initial period, management, medications, everything is available in Sri Lanka. We can manage them quite effectively.
And talking of this illness, since it is not only a tad tedious for the patient but also for the family, like watching their loved one going through this phase. So is there scope in here, doctor, to obtain advice or counsel on how to cope with this and how to make it a little more bearable for the people concerned?
Yes, Parkinson's disease patients, we see quite a number of patients because we are neurologists, but it's not very common like stroke patients in the community. Advices, of course, usually received from the neurologist usually, and different patients might need, advices tailor-made to their, lifestyles and so on. But one thing I must mention with patients with Parkinson's disease, exercise seems to be very good, and in fact, dancing. There was a recent, not very recent though, research in Japan. They have a dance by the name Taiki. I don't know if you have heard it, and they have proven that patients who do this dance, which has sudden jerky movements and slower movements and so on, is effective, and they are saying that probably dancing and exercise have a disease modifying effect, indicating that the progression of the rate of progression probably is declining in those who exercise very frequently and physically active, rather than being in a house and then seated all the time and taking the medications.
Right, now that you mentioned that word, dance, doctor, talking of dancing and music, it is a special therapy in itself, isn't it? It aids and helps loads of illnesses, because they say that, if I'm correct, even those who are maybe having a brain stroke and maybe not conscious, but they can still hear the music and the sound waves. Is that correct?
That's correct. In fact, we use music therapy for certain patients who are, certain patients who are having life-limiting illness, patients who are seriously ill, and patients having, multiple, problems and, a disease causing so much of agony to certain patients. There we, as a team, certain strokes also are like that. When the patient is bedbound and dependent on others, and they get exposed to so much of problems. So we employ music therapy. We don't have it in the National Hospital right now, but it's a form of therapy that is happening elsewhere in the world.
So I guess neurology and music go hand in hand, and well, that's why, doctor, I was told that in your spare time you enjoy music and are a versatile musician. You can sing well and you also play the keyboard.
Yes, I'm coming from a family, of course, a lot of musicians and music teachers, and I'm coming from a family with 8 members in my family, so all of us are, when you have some leisure time, we get together and sing and, and dance and so on. So this practice keeps going in my batch, in my medical career. In fact, there was a period where medical school was closed during my period, so we had a band in the faculty, so we played certain occasions also.
So, music-wise, like you told me, you mentioned that you had recorded some songs. Were they your own compositions, or?
Yes, I did some songs. I composed a few songs. It's available on the YouTube if someone wants to listen. In fact, the words, the lyrics were done by a few of my friends actually. They're all medical consultants. So, leisure time, we need this work and life balance. So
that's right. And if you could tell us what the name of the song was so that we could check it out on YouTube.
There are a few cover songs. If you type my name and then you go to the YouTube channel, it's there. Most of them are Sinhalese songs.
Right.
One written by Dr. Ranjit Pera, who is a general surgeon at Ragam right now. And there were a few others written by Dr. Chandana Mohati, who is an orthopedic surgeon. And I did the music, and I had this digital audio workstation at my place, so I added the music also, and I sang also.
Right. That's right. You're doing Radio Sri Lanka this Tuesday morning, and it's the coffee hour. And our special guest in the studio is Dr. Gamini Pathirana, consultant neurologist, National Hospital of Sri Lanka, talking on a very wide and broad topic of neurology and its effects and impacts on us. Well, doctor, talking of dementia, statistics say that about 55 million people worldwide have dementia, with Alzheimer's disease being the common form of dementia. What really triggers Alzheimer's, and what are some of the early warning signs of it, doctor?
Well, Alzheimer's disease is a disease of older age. Right. And Sri Lanka is currently experiencing aging population. Mm-hmm. So we are expecting to see more and more Alzheimer's disease patients in this country. So when you say dementia, Actually, people, try to make a mistake where you cannot distinguish whether this is something to do with memory alone.
Right.
Here in Sinhalese, we say loss of memory. You cannot remember things, but memory is just one function of the brain. And when you say dementia, actually, it's a dysfunction of many brain functions, not only memory. There are so many other functions in the brain, like your language, your ability to speak, and then your ability to describe things, so many other functions. So your visual, spatial, navigation abilities. So, in fact, Alzheimer's disease, the first symptom is loss of short-term memory. So that is why people try to name it as a problem with memory. Memory means ability to listen to information and store them, and then also, you
Use
retrieve
that information.
Yeah,
yes.
you retrieve this information back again. So people can go wrong with short-term memory or intermediate memory or long-term memory. Alzheimer's disease usually starts with short-term memory loss. You find it difficult to remember the stuff that you did just now. So in fact, the first place you find problems is at the workplace, because to work you need a lot of short-term memory in your, as a brain function. So when the memory problem comes to the stage where you cannot function, you cannot continue to work, or you cannot function in your day-to-day activities, then we call dementia. Dementia is common. What triggers dementia? What causes dementia? It's probably genetic, and we understand the disease to a certain extent. We understand there is deposition of amyloid, which is a protein within the brain of them, and if you dissect the brain, use the Alzheimer's, who describes this initial few patients. He dissected the brains of a few patients whom he saw as, having dementia, and he described pathological terms. In medicine, they call it plaques and tangles, which are descriptive terms to indicate what they see on the brain,
right,
which is a hallmark even at present. So later on, we understood that Alzheimer's disease patients have deposition of protein by the name amyloid. Amyloid is it's a existing protein in the brain, and it cleaves in physiological way. It doesn't get deposited in the brain, but for some reason, when it cleaves in a pathological way, it produces various unwanted chemicals that gets deposited, and the scientists believe that may be the cause, but we are not 100% sure whether this is just an innocent bystander among them or whether it's actually the cause. But scientists are, doing research at the moment, trying to get rid of this amyloid deposition or control the deposition of amyloid, and using various vaccines to see whether we can control this disease. There's so much of money allocated worldwide for dementia research, and people believe in time to come we might find a cure or maybe a disease-modifying treatment.
So in Sri Lanka, what is the treatment, the management, and the scope, doctor, currently available to manage Alzheimer's and dementia here?
When a patient arrives to me with dementia, well, I look at, there are a few treatable or curable causes. We must look for them. And if they are there, they are not Alzheimer's, they are something else. Maybe your reduced thyroxine levels can do this, or maybe certain vitamin deficiencies can do it. And there are conditions like normal pressure hydrocephalus, which is surgically treated to stop progression of dementia. So there are a few treatable conditions where doctors will be looking at. And when you diagnose Alzheimer's disease, certainly we don't have a cure. We don't have a curative treatment, but there's so much we can do for them. And there are, again, I was mentioning about neurotransmitter chemicals,
yes,
where the chemicals talk into between the nerves. And there's a chemical by the name acetylcholine, another chemical in the brain, seems to be deficient in patients with dementia. So doctors, when they are treating Alzheimer's disease, they use a medication to try and increase the level of acetylcholine level in between these nerve cells. That treatment controls the clinical symptoms to a certain extent in the initial phase, but they are not curative. They are not going to be effective for a long period of time. But largely dementia patients management would be looking after the symptoms and the problems that the carer experiences, because looking after a dementia patient, being a carer for dementia patient, I feel is the most difficult task on earth. People who have been looking after dementia patients, sometimes they also develop psychiatric issues. So I make it a point to speak to them and make sure one of the important aspects from the doctor's point of view is to speak to the carer and make sure that the care is also good, because carer is the main key person who will be helping this patient. So care education is necessary. Looking after a dementia patient, you need education. And in Sri Lanka, we don't have a formal education system, but I advise people to go to the YouTube and see education videos are available for carers, how to look after a patient with dementia. And that will help them to look after the patient better.
And if I'm not mistaken, we have an Alzheimer's Association in Sri Lanka, do we?
I think it is there. I'm not very particular about it.
Right. So anyway, so basically that means a neurologist is the one who would be giving counsel and advice on the management of a patient with dementia to the carer, isn't it?
Yes. There's so much of things that the carer should know when the patient, keep on asking the same thing again and again. Yes. I ask the carer, you just keep telling them. And there's no point in trying to explaining certain things to a patient with advanced dementia, because they will not retain things and they may not argue. So best to, agree with the patient rather than getting into a debate with them, and then have a smooth environment at home. And one of the tactics or strategies that carers use in managing dementia patients is to distract them. When you keep talking on a particular point, if you distract to another area, you can stop that argument going on. Otherwise, you'll have heated arguments at home and very difficult to manage. Sometimes there are children looking after parents. They have to honor the parent.
Yes.
So sometimes they find it difficult to go against what the parent says. But then we must understand, when it comes to moderate or advanced stage of the dementia, your mother or father is a completely different personality. They're not going to be the same usual mother or father. So you need to put a lot of effort to control their behaviors, otherwise it's difficult. It may be sometimes injurious to the patient.
Yes.
When they behave abnormally.
And in case they maybe just take off by themselves, isn't it? Because then they won't know basically where they have come from, where they are going.
Yes. And sometimes they go out of the house.
That's right.
In the usual, as a habit, they just go out of the house and find it difficult to find their house back again.
That's right.
So they have difficulty navigating. Inside the house also, sometimes they find it difficult to find where the washroom is, and then they just pass urine in the room. So sometimes carers tend to put, labels. The toilet is there, and your whatever frequently required things, you put a label on the wall with an arrow. Your watch is here, so that they will find it easily. And a clock, maybe a calendar with big letters, so that they will be oriented in time. And also not to have too many visitors to see them, because they cannot. The dementia patients cannot tolerate too much of inputs, the stimuli. So must have minimum amount of stimuli.
And when we talk of their memory loss, doctor, is it a total blank, or is there some part of their memory that is still there, maybe the recent things or things of the very past, or is it just a total memory loss?
The very past memory usually is intact until late stage. In fact, as the disease progresses, they try to live in their old age. I have seen some patients, in the morning you get up and you put your shoes and then try to go for work.
Right.
They go back to their usual previous, time. So previous memories, the past memories are usually intact until last stage. When it comes to last stage, everything goes, and patient, the last stage, they go into a palliative phase where it's very difficult to control the symptoms.
Right. So, doctor, in our concluding minutes, is there anything else you would like to add in the sphere of neurology when we were discussing during the music break, you mentioned a few interesting things. Would you like to tell us about it, please?
Yeah, few neurological problems that we did not discuss is one is numbness in the hands, very common, carpal tunnel syndrome, and people keep suffering with this disease and find it difficult to work, and sometimes but the carpal tunnel syndrome has a clear answer. Very tiny surgery can relieve it for your life. You will be completely symptom free after the surgery. So if you're having numbness in your hands, and then when you ride the bicycle, your hand become benumb, and when you go in the bus, your hand become benumb. When you keep the phone, holding the phone for some time, your hand become benumb. So that may be a few symptoms that indicating that you are having carpal tunnel syndrome. There is a nerve in the arm by the name median nerve, which travels through a very tiny tunnel across the wrist, and there it can get compressed. This nerve compression is the reason why you experience all these symptoms. If you are using hands for your work every day, I have seen this phenomenon in tea pluckers and people who use machineries. They used to get this problem. If you are having these symptoms, it's a treatable thing. You can be completely free of symptoms if this tiny surgery is done. The who needs surgery is explored by a nerve conduction test. If you see a doctor, they recommend to get this nerve conduction test, and that will prove or disprove whether you are having this condition.
And talking of numbness, doctor, in the hands you just mentioned, sometimes people experience numbness in their feet when they are static for a long time. Maybe we are talking of non-diabetic people. Is that a cause for concern?
Well, non-diabetics having occasional numbness in a big toe or toes or feet.
Or the feet, yes.
Yeah, if it's persisting, yes, it's a concern. But if it comes and goes and not causing too much of trouble, I don't think there's so much to be concerned about. But a lot of people can develop numbness in their feet, excluding diabetes. There are other causes, like, if you take too much alcohol for a long period of time, you can get this numbness in the feet. And also, if you are deficient in certain vitamins, if you are choosy in eating, if you are deficient in thiamine and B complex and so on, you can develop this. But they are not so common, because usually most of us are getting a balanced diet. And certain drugs can do this, especially chemotherapy. In cancer patients, they can develop numbness in the feet, which is not going to progress, though. The moment the chemotherapy stops, the effect on the nerves also stops. And diabetic neuropathy is very common, and people who have peripheral neuropathy, which is benumb feet with burning sensation in the feet, you can't sleep at night. Diabetes is a reason for this neuropathy. It's very common, and it can be controlled. So you need to discuss with your doctor, and you can control this pain and the bad feelings in your feet, and also we can control progression of the peripheral neuropathy in the feet. And
doctor, may I know whether sleeping disorders also comes under the sphere of neurology?
Yes. There are so many sleep disorders in neurology. It's quite common, and we have, in fact, in Colombo, we have a sleep lab where we investigate them. There are so many problems associated with sleep.
Right.
Like for example, some people, do not know whether we have enough time to discuss that. Sleep is not just one phase in the night. We go to sleep and we wake up in the morning.
Right.
We think it's just one phase. It is not so. We can look at the electrical activity of the brain by doing a test called electroencephalogram, which is a counterpart of ECG that you do on the heart. ECG records the electrical activity of the heart, and electroencephalogram records the electrical activity of the brain.
That's the EEG, right?
EEG.
Right.
If you do an EEG in a sleeping patient, we identify there are few phases that they go through during the night. There are basically two major phases. One is called REM phase, the other one is called non-REM. REM stands for rapid eye movement. If you see small kids sleeping or puppies sleeping, you can see at various phases they through the closed eye, you can see the eyes are moving rapidly.
Right.
So there is a phase during your sleep where your eyes move very fast. So that phase is called REM phase. And during this REM phase, which is not a very deep sleep, you dream during this phase. Actually, you dream during your sleep in the rapid eye movement phase. And during the REM phase, you can dream, but you cannot act your dream because your muscles are paralyzed. They are not having tone. You cannot do them. But there are conditions where your paralysis is not there. So when you dream, you try to do various things. I have seen videos where people walk during sleep. You go to the kitchen and, eat in the night. And sometimes in the morning, you go to the kitchen, the stuff in the kitchen were missing. Yes. Someone has eaten. And the fellow doesn't know that he had done it. If you have videos, he will find out that he himself had done it. This is a dangerous situation, doing things during sleep. And most of the time, you kick the bed partner. And bed partner come and say, this fellow is kicking me in the night. This is called REM sleep behavior disorder. This is common with Parkinson's disease also. So they are treatable. We have medications effectively to treat them. So if something happens during sleep, some of them have, sleep terrors and, breathing problems and various things happens during sleep. So if you have any problem during sleep, we need to get into the root of it and then find what's going on.
So basically, per se, some people say they find it hard to fall asleep. Is that a sleeping disorder, or is it just a very common thing that...
sleep...
or the sleep is disturbed.
Yeah, so when you go to the bed, you don't go to sleep immediately. There's a, we call it sleep latency in neurology. So sleep latency is quite low if you are a sleep deprived person.
Right.
And if you are sleeping adequately, your sleep latency will increase. So you take longer to get into sleep. You go to bed, you close your eyes, but the sleep doesn't come. Take a long period. Probably the requirement in the system for sleep is minimum. And there are various disorders which does this. On the other hand, there are patients who go into sleep very easily.
Right.
We call them sleep attacks. Certain people with, for example...
That is basically you sleep while you can even sleep while you walk.
Exactly, while you drive, and people have met with accidents.
Yes.
They call it SOS, sudden onset of sleep, because the sleep latency is so reduced that you fall asleep immediately while you drive. You don't feel it, you just fall asleep. And they find it difficult to drive vehicles also. A lot of sleep disorders are there. And if you have any problems with falling to sleep or sleepiness during daytime, or you don't have a good sleep during the night, sleep is disturbed, you need to consult a doctor and discuss with them, doctor.
So in your concluding comments, doctor, is there anything else you would like to add on this topic?
Now, being a neurologist, as a preventive measure out of the disorders that we discussed, stroke is actually my pet subject.
All right.
And stroke is quite common, and stroke is causing so much of disability. And in our society, there is a significant number of disabled individuals from stroke, and stroke can be prevented. So one of the risk factors among many that we mentioned is actually unawareness of you are not aware about stroke is also a risk factor. So if you are aware about stroke, if you are educated about stroke, you have less chance of getting stroke. So read about stroke, listen to stroke education material, and disseminate the knowledge among the whole community, talk to others, let everyone understand what is stroke and how can you prevent it. And by preventing stroke in the society, you are making a contribution to the society.
Thank you very much, Doctor. It has been wonderful being in conversation with you this Tuesday morning, and together with our producer, Indira Navagamur. May I thank you very much, Doctor, for taking your time off day and beginning your day with us here in the studio to enlighten us and to broaden our knowledge on this vast area of neurology.
Thank you, and thank you for inviting Soumdi and Indira, both of you.
Thank you very much, Doctor, and may I wish you a lovely day ahead.
You too, thanks.
We were in conversation with Dr. Gamini Pathirana, consultant neurologist, National Hospital of Sri Lanka, on a topic of neurology and what it means to us.
The Coffee Hour. Welcome to Coffee with our morning host. We broadcast a host of programs like current topics, newspaper headlines, and music on Radio Sri Lanka. Tune in every weekday from 7 to 8 a.m.